Hello there, many thanks for joining us once again for another edition of Talking Point. And tonight we'll be talking about financing the National Health Insurance Scheme. My name is Abdul Hai Mumin, and I'll be your host for tonight. I'll give you a brief gist of the discussion tonight, proceed to introduce to you my panelists, and then we'll kickstart the discussion. Now, in 2003, Ghana passed into law the National Health Insurance Scheme, which is also known as the NHIS, which is managed by the National Health Insurance Authority as a social protection policy to protect the poor and marginalized from the catastrophic health policy, catastrophic health effects of the then cash and carry system. Currently, the National Health Insurance Authority reports a coverage of 34% of the population, and a majority of these active members are the indigents, the aged, and children below the age 18. Yet access to quality healthcare is still far below expectation. The NHIS, however, is still the best option to achieve universal health coverage in Ghana. But the key challenge is how to ensure financial sustainability of the scheme in the short, medium, and long terms. Tonight on Talking Point, we shall discuss sustainable financing for the National Health Insurance Scheme as a tool for achieving universal access to healthcare in Ghana. Once again, my name is Abdul Hai Mumin, and with me in the studio, and I'll start the introduction from my immediate right, are Mr. Nathaniel Otoo. Mr. Nathaniel Otoo is the Acting Deputy Chief Executive in charge of operations at, I'll be giving you that as we proceed. Well, that's Mr. Nathaniel Otoo in your shots at the moment. And next to him is Dr. Steve Manteaw. Dr. Steve Manteaw is the campaigns coordinator of ISODEC. And then next to him is Mr. Sidua Hor. Mr. Sidua Hor is the National Coordinator of Universal Healthcare Campaigns and a Health Policy Analyst. Gentlemen, you are very welcome to Talking Points, and I hope we'll be having a very fruitful discussion tonight. Let me begin with you, Mr. Otoo, because the general understanding is that every worker in Ghana pays about 2.5% of their contribution to the Social Security Fund. And then also, anytime we go to buy anything from any supermarket which is VAT chargeable, we also pay 2.5% contribution to the National Health Insurance Scheme. Now, knowing that we make these contributions, first of all, can you give us a general idea of the state of the National Health Insurance Scheme as it is, even as we speak?
Well, thank you very much. That's quite a ton of a question, but I'll attempt to do justice to it. Yes, indeed, workers, formal sector workers make what we say a 2.5 percentage point contribution to the NHIS from their Social Security. And in addition, when they consume VAT or NHIL-rated goods, they do pay as well. Now, the reason why that happens, in the wisdom of the framers of the law that guides the NHIS, is that when you look at social protection generally, there are many principles that underline it. For example, those who are able to pay support those who are not able to pay. When you come to the health sector, the healthy will support the sick. So it is a good principle. Now, if you asked me about the state of the NHIS, I would say that the NHIS, from the date of inception, has done extremely well. The NHIS currently enrolls 34% active membership of the population. And that is coming after about 7 continuous years of implementation. As you know, even when the rate stands still at 34% next year, it would have organically risen by a rate of about...
You know, and I'm glad that we have ISODEC here, because they have done a research on these figures that you've begun to give us even before we delve into the details. And this 34% is even contestable, because previously you gave us a figure of 67%. And then we heard about 18%, and now it's shot to 34%. Why do we have these figures dangling about, and which one do we really trust?
you trust all the figures. They come in a context. When the NHIA started in the first years, the only way you could account for the numbers was to add. Come 2 years after implementation, that became something that was no more tenable. So we started to change the way of reporting. But at the same time, the accumulation continued. And we did state specifically in our 2009 annual report that for that year, we had changed the way the reporting was done. It is in order to cut any duplications that were going to be. Yes, indeed, ISODEC was right to have pointed that out. And it fed into the attempt that we were making to sanitize those figures. So it was a comment in good time, you know, when it came.
Okay, so I'll give Mr. Doc, I'll give you the chance to respond to what Mr. Otoo has been telling us, and then also give us your own perspective. And I'm talking about the ISODEC report on this 67%, 34%. Later we had 18%. Which one do we trust?
Thank you. I think, as a point of correction, the report was not an ISODEC report, although ISODEC
you were part of it. That's what I meant.
Yes, yeah. But it's a report that was produced by a coalition that was working to promote universal healthcare in Ghana, and so it's one that we all share together with our partners in the coalition. I need to say that the financing arrangement for National Health Insurance Scheme, as so to indicated, is what it is. But then we should not construe that to mean the total financing arrangement for healthcare in Ghana. Because healthcare, just like any other social service in this country, is to be financially from the budget. And in Abuja, countries in the region, I mean the African region, committed to what do you call it, contributing to healthcare about 15% of their budgets. Unfortunately, many countries, including Ghana, are nowhere near the 15% commitment pledge that was made in Abuja. Currently, we're doing about 9% of our budget in terms of the percentage of budget that goes into financing healthcare in this country. I think that there is, in terms of the financing arrangement for the National Health Insurance Scheme in particular, we need to have that discussion within the context of also inefficiencies that exist within the system, and which in itself imposes cost to those of us who pay premiums to be able to access these services. So the administrative inefficiencies in terms of over-invoicing that are sometimes the case in some of the claims that are made by healthcare providers and all that, goes to compound the total cost of the service that is provided at the end of the day. You find that premiums from district to district sometimes have had to be reviewed upwards. And this is because of perceived rising cost of delivery of the service. But you see, the delivery of the service also has a huge component of administrative cost, which if we not deal with the administrative inefficiencies, we'll end up passing on that cost to those who enjoy the services of the National Health Insurance Scheme.
So, Mr. Hor, what do you also make of the current state of the National Health Insurance Scheme?
Thank you. I think that the sustainability is an issue, and in a way a question, because we have reached a point where we've realized the importance of the scheme, and yet we are confronted with the issue of its sustainability, and that boils down to the issue of the financing. Like Steve said, if you look at the financing arrangement or the model, you have 3 key components as the sources. That is the VAT contribution, the SNCC contributions, and then the annual health insurance premiums. Now, over the period, you will realize that the annual premiums component is actually struggling. As we talked today, it's 4.3% of the total revenue. In reality, this should have been the backbone of the financing arrangement. As it is today, it is the VAT, which is the tax component. So clearly, if you also put in the context of what Steve raised, if you subject the whole business that is considered the National Health Insurance Scheme as a business, if you subject it to the business model, you realize that it doesn't, in terms of its cost benefits, and it doesn't work because the VAT is collected by the revenue services. Now, if you take the premiums, that is actually the business of the National Health Insurance Authority. They and their systems across the country collect that money. Now, if you should compare their administrative costs or running costs to actually how much they raise from the annual premiums, then you realize that then we're running at a serious deficit. And so the amount of money that we are spending to collect this money is actually not worth it. So it means we may have to look at the arrangements in terms of financing it. But that doesn't mean that the scheme is not important. The scheme is very important. And if we are able to tweak it and fix the financing arrangement, then it will be the best vehicle to provide Ghana universal access to healthcare free at the point. You know,
I've been looking at one report from the group where you belong to. Is it the Universal Healthcare Campaigns Group? Yeah. And the report sought to suggest that the objectives set out by the scheme have really been defeated. Is that really what it is, or I misinterpreted what I read?
That seems to be the case because right now, what is the coverage? It's 34%. Now, if we subject this 34% to critical analysis, like you read in the synopsis, majority of these, this group are the exempt.
We've just been told that the 34% that we are working with at the moment is in a certain context. At some point, I don't know. You tell me about it.
Because that's the context I'm saying, because majority of these are the indigent. That is those 18 below, the aged, and then the pregnant, free component. Yeah. Okay. Now, how many or what proportion of the population of this 34% actually pays the actual annual premium? That's the question we have to ask. So that is the issue to interrogate. If you want to pull out the quantity or the proportion that actually pays year by year, it is very negligible. It tells us that we are not able to raise money from the premium. Many more people are not registering. Why are people not registering? It may be an issue of affordability for those who are very poor, and it may also be an issue of efficiency. Maybe people are not getting value for money. We also need to interrogate what is the quality of care that people are getting for those who are able to register.
Okay, so I'll give the chance to Mr. Otoo to respond, and then
okay. So that just to yes, right. We need to have a discussion with understanding that the National Health Insurance Scheme is a social protection scheme, okay, and therefore targets the weak and the vulnerable in society. And so for me, we need to be very careful not to raise premiums. Such a scheme must be funded largely from taxes. And the kind of tax revenue that we target should be the progressive type of taxes, not the retrogressive one, not the type of taxes that makes no differentiation between the rich and the poor. We should be able to, and I think Mr. Nathaniel Otoo made that point, that we need to, it's a situation in which you try to make those who can afford, the rich and affluent to society, to cross-subsidize the access to health for the poor in society.
See, so we are speaking in a context where Ghanaians, many of whom are paying their taxes, are complaining that it's too much. The rate at which they are paying the tax is too much. And that even the people within the tax net are just a few. And that we have a larger group of people out there who do not pay taxes. And that the solution is to look for ways of getting those people into the tax net instead of rising or raising taxes. Is that what you are suggesting? That we should raise taxes and the few people who are paying the taxes will be further burdened?
I think Ghanaians are not complaining about just paying too much taxes. The reason we are hearing this complaint is that people are not seeing their tax money working for them. Okay, for instance, let me give you an example. I travel on the motorway every day. Motorway tolls have been increased by how many times? Over 1,000 times. And I cross the barrier and immediately I hit a pothole. Of course, I'll complain about taxes I'm paying. But if I see my tax working for me, I'll be more than happy. So we need to move from the regime of imposed taxation into consensual taxation, where people are happy to pay because they are seeing the value of the taxes they are paying.
We'll come back to the issue of taxes, but quickly, I'd like you to respond to the issue, and I'm particularly interested in the figure that we need to work with. What is the true figure? Is it 34? Is it 18? Is it 67? You were talking about a context. Let's clarify that, and then we can move on.
Well, I explained. You said a true figure. There is no false figure, let me say. The thing
but
is,
we are having so many figures
the
around.
the figure that you have is the one that comes from the NHIA. The NHIA is saying, based on the systems that it has, that 34% of the population is active. We say those are active members of the NHIS. That is what it is. The paper that you referred to was an inference. It was an extrapolation based on a certain analysis that was done. I think the simplest thing to do, if I asked you how many residents are in your house, is to count the people.
That's right.
When you count them, you have the number. But when somebody else comes and says, because of the size of your house and the number of rooms, there should be this number of people, that extrapolation might or might not be right. Now, the point that was made, which I agreed with in the report, was that we needed to have a systematized way of reporting, and I think it was fair. But that analysis that was done was just to suggest that the NHIS reporting ought to be approached in a certain kind of way, which we are approaching in this way. It is the number of people holding cards who are able to access healthcare that we call active members, and they are 34%.
Okay, so let's come back to the issues that concern the ordinary Ghanaian out there. The NHIS, from my understanding, from my layman's understanding, was supposed to ease the burden on the poor Ghanaian. Now, you go to our health institutions today, and those same poor Ghanaians, in spite of the fact that you have visible presence of the NHIS, are having to pay out of their pockets on the spot for services to be delivered. That is what we are seeing on the ground. How do you react to this?
We do hear some of those complaints. But let me say here and now that the NHIS, the NHIA, does not endorse co-payments. The fact is that the NHIS has a package. The package is costed, and that cost is accepted by contract by the service providers. If a service provider charges anything over and above the tariff that has been agreed, then they are doing something they ought not to be doing. And the NHIA, in order to make sure that we get full information of such nature, we encourage people who have, faced co-payments to make a report. On our own, we have actually proceeded to do audits where we have found co-payments, and we have deducted and penalized those providers. It does happen, yes. When it comes to our attention, we take action on it.
Okay, you see, the issue is not just that. Sometimes you go to the counter to purchase a drug which is supposed to be under the NHIS, and they tell you that drug is not available, and that you have to rely on a different drug which is not under the NHIS policy, so you have to pay.
Well, I explained.
We have several of these cases across the country.
But remember that those who are selling you services are selling services, when I say services, those who are purchasing services from, would like to make good money. Now, the law as it is here in Ghana and elsewhere, as far as public money is being used to finance healthcare, is that as far as possible, medicines that are given should be generic medicines. This is so that the money can go around. You see, when we refer to generic medicines, they are not inferior medicines. They are medicines that are simply out of patent, okay? But in healthcare, there's something that is called asymmetry of information. I mean, if you are sick and you get to the health facility, the expert who is there, when they tell you something, you take it. It's not the point at which we are going to argue. What is important is for us to continue strengthening our monitoring, which we are doing. But we do encourage, and we say that NHIS does not belong to the NHIA, it belongs to the generality of all Ghanaians, and we have a duty to make sure that it works.
Dr. Manteaw, so this scenario that we are setting here, and which we all agree, or well, he has agreed to it, and he's from the health insurance, from where ISODEC sits, do you see the same thing?
Yeah, we do, and I think I alluded earlier to the problem with administrative inefficiencies and all that. I like the point Mr. Nathaniel Otoo makes about penalizing those who go against the law with regard to these out-of-pocket payments at the point of service delivery. But you see, we need to be very clear, and I would want to also find out from the National Health Insurance, for instance, what kinds of monitoring and compliance arrangements they have that takes into account, for instance, also the receiver of a service. So, for instance, I go and I'm told that, look, you cannot. What kinds of arrangements are in existence that allows me to give the National Health Insurance a feedback to be able to follow up and ensure that this manipulation of the system unduly to the advantage of the service provider is kept in the bag.
Okay, and I'll be coming to Mr. Hor when we return from the break, and I'll be asking him, and he's from the Universal, Universal Healthcare Campaign, so I'll be asking him whether the NHIS really qualifies to give us universal healthcare right here in Ghana. We'll be back after the break. Please don't go away. This is Talking Point.
Yeah? Don't tell me the child has diarrhea again. Oh.
What can I do? We haven't slept all night.
Now, there's a better and more effective way of treating child diarrhea. ORS plus zinc tablets.
Zinc tablets, when combined with ORS, offer the best treatment for childhood diarrhea.
We know ORS, but I'm just hearing about zinc tablets. So why zinc tablets?
On the first day when your child gets running tummy, immediately start giving the child ORS just as you did before. Give 1 zinc tablet daily for 10 days. The full 10-day course will provide protection from diarrhea for up to 3 months.
Really? Protect my child from getting diarrhea for 3 months?
Yes, and it's now easily available and very affordable at health facilities, chemical shops and pharmacies. ORS plus zinc tablets stops diarrhea faster and protects. That's your good life. Good life goes with good health. Good life, live it.
Brazil's World Cup fever kicks off with the Tournament of the Champions, the Confederations Cup.
And a goal for Brazil!
And the Black Satellites of Ghana clash with the rising stars of world soccer in Turkey for a showdown.
With a screamer for Ghana!
The FIFA Confederations Cup in Brazil and FIFA Under-20 Youth World Cup in Turkey. Catch all the action and goals live on GTV, Metro TV, TV3, GTV Sports Plus, Net2 TV and ATV Ghana. For sponsorship, contact OMP, Official Marketing Agency, on 0244 238 255.
Right, welcome back. This is Talking Point, and we are discussing financing the National Health Insurance Scheme. And with us are 3 distinguished gentlemen. Mr. Nathaniel Otoo is the Acting Deputy Chief in charge of operations at the National Health Insurance Scheme. Next to him, Dr. Steve Manteaw. He is a campaigns coordinator at ISODEC, and Mr. Sidua Hor is the National Coordinator of the Universal Healthcare Campaigns, and he is also a health policy analyst. So I'll begin this round with you, Mr. Hor. And, you know, we're trying to implement a universal healthcare coverage in this country. But let me ask you, is the NHIS the best approach?
Absolutely so. It is so because currently, like we have discussed here, the vulnerable segment of the population are in a way catered for, even though that's not perfect. For example, we have the pregnant women having access to some free healthcare services. We have children under 18, and we also have the aged. This constitutes, in some way, the vulnerable section of the population. Now, so if the scheme makes provisions for them, and then we are able to also cater for the working population, then I would say that it is the best tool. However, we need to fix it, and it is the reason why we are here today, because it means we need to be able to look for the sources of financing or the resources that we need to be able to put it on its feet in order that people can have access to quality healthcare services. I say this because if you look at the current arrangement, it means that we are not getting enough money to be able to provide the services that these groups or these vulnerable groups are already consuming. So what we have to do is to probably go the tax financing, because the insurance component, the VAT component has proven that it is most reliable, it is effective, and then it is one that we can really be assured of. So we may have to probably expand the tax base, probably looking for some taxes or revenue from the alcoholic beverages, because they impact negatively on the population's health. You know what alcohol is doing to the populations. we also know that tobacco impacts negatively on people's health. So if we can put some taxes on these, known as sin taxes on some of these products, and then we'll be able to rake in more money. And the informal sector. And
how different are these taxes going to be from what is already in place? We are paying VAT. Anytime people buy tobacco, I suppose, they do pay VAT, and 2% of that goes to the NHIS.
You know, the thing is, VAT is progressive. It taxes relatively those who are more wealthy. There are certain products that, when we consume them, they are put in the brackets of the affluent. Okay, if I go to KFC today and go and buy rice, for heaven's sake, that is at a higher level, okay? But I can still get food to eat that is decent, that is not at that level. So you pay more. Alcohol is not a necessity. It is a luxury, okay? So if you should look at paying more for your health and pay more for alcohol, which one will you take? So if it is not one that the population will really complain about. Of course, people who are consuming alcohol will complain, but not as in the case of income taxes. If they had put a flat tax on income taxes, that is not fair, because in that case, that's regressive. But if we say that those who earn more should pay more, that is progressive. So tax-based financing is a solution to our healthcare financing needs. And for me, if we are able to go tax-based financing, then we'll be able to raise more money. We are not saying that we should burden the Ghanaian worker. That's not what we are saying. We should review the existing...
I have a little difficulty, because what we have been reiterating here this evening, all of us here, is the issue of people who earn more. At what stage or level do you say that this or that person earns more? Because you ask every individual Ghanaian who is a worker, and I'm sure that no one will tell you that my salary is enough for me, and no one will be happy to be taxed on the current salary.
Point is this, the salary, people are paid on payrolls, okay? We know how much each person pays. Every company has
So what's your proposal? That from, say, 100 cities to 500 cities is below your level?
Currently, we have an income tax, and that's operating fine. We are not even talking of income tax. That's not what we're talking about. Outside that, there are other taxes we can collect. And I just mentioned alcoholic products and tobacco. When we go outside that, we can look at environmental tax. To what extent are we collecting it? There's so much pollution going on in the system, and that impacts negatively on our health. Beyond that, let's look at corporate tax. Are we calling it property tax? There are so many burdens. Look, how much is rent in Accra? That is commercialization of property.
And so all these taxes, when all these taxes are collected, they should be brought to the National Health Insurance Scheme?
No. Proportion of that can be brought to the healthcare. But we are saying that we are simply not collecting taxes in this country. Property tax, property owners are making a lot of money out of rent in this country. Are we really taxing them properly? You know, it's very expensive to rent a house in Accra, Kumasi, etc. How many of these are paying tax? We need to let people pay tax, and then we can channel the money into healthcare, because healthcare is one that is very important. You should not forsake, and at that time, then you begin to look for money. We should contribute for it at a time we are healthy, so that when we are sick, then we can have access to quality health care. So I am saying that the National Health Insurance Scheme is the best model that can guarantee us universal access to health care. But we probably need to look at the annual insurance premium component, because that aspect is not working well. The other two components are good, and then we can probably look at tax-based financing. The informal sector, there's a lot of money that we are not collecting. The artisans, people weld things from morning to evening. And in a way, the money is collected and it goes to individual packets, or it's not collected at all.
So these are brilliant observations you've made. So outside of the observations, have you made any efforts to get the proper and right authorities know about these and take action on them? Have you done anything at all about it as a coalition?
That's why we produced the report. And the report did the analysis and realized that the coverage figure as at that time was exaggerated or it's inflated because it was not active members. We said that any insurance model, you can only say X number of people are on it because they can access healthcare. If somebody has an insurance and it's expired, you don't count that, because that person cannot use it to access healthcare. If the person probably died, you don't count that. And so that was why the report said that the coverage at that time could be as low as 18, because they were counting cumulative figures. It was in a way to contribute to make sure we sanitize the coverage so that we know the actual figure we are working with. Beyond that, we said that at that time, that was 2009, we projected that around this year, last year and this year, the scheme will not be financially sustainable, to run into some problem. And of course, we experienced it. And we suggested or proposed in that report that we need to consider tax-based financing as well. We suggested a couple of things, which includes the alcoholic products, tobacco, etc. And today, these are some of the proposals that the National Health Insurance Authority has taken. We also said that there was a lot of corruption or leakages within the system, and that there was a need for the National Health Insurance Authority to institute clinical auditing, because there were instances when private health care providers were inflating claims, and that's thievery. It's stealing.
We'll come to the issue of. We'll come to that issue. It's a very dicey one. We'll come to it as we progress. But I'd like Mr. Otoo to quickly answer this question. You know, and it has to do with the levies that we are collecting right now. Are they adequate from where you sit?
Well, first of all, let me just clarify a few issues that.
And I hope that hasn't got to do with the corruption, because I'd like to reserve
well,
that.
I
Yes.
will deal with that.
Yeah.
But he continually has been mentioning tax-based financing. We have to clarify that, because the NHIS is largely tax-financed. 78% of all the financing for the NHIS comes from the NHIL. About 18% in 2012 came from Social Security transfers, and the rest from other sources, including premiums. So as it is designed, the NHIS is already heavily tax-financed. If what you're referring to is complete tax financing of health care, that is another matter altogether. And I think Ghana will be one of the pioneers in the world for that, because even the UK, with its renowned, NHS, has just about 75 thereabouts % financed directly from taxes. The rest are financed from payroll, and a little bit from co-payments, about 2.1%, which people seeking healthcare do. It would be nice if the country could absorb that and let tax financing be the way forward. But remember, the way we are doing the NHIS is a journey, and we should proceed stepwise in a way that the country is able to handle. When you talk about healthcare financing, you are not only looking at the taxes, you are looking at a lot of things. You are looking at the demographics, you are looking at the political economy, you are looking at epidemiology. What are the sickness, incidents in the country? What is the infrastructure? We are looking at a lot of things that intersect to make the financing model that we choose sustainable. And that is what we are all looking at. Yes, we will do with some more tax money. But as it is, when it comes to taxes, it does not necessarily mean that increasing taxes will get you more money. Second thing, I think I want to address this, and I've heard quite a lot of allusion to inefficiencies, and the NHIS has met this. The NHIS has met this head on. As you know, in 2012, the Act 650, which is the law that established the NHIS, was streamlined in order to take away governance problems, duplications of activities, and so on. So we are poised to improve the efficiency of the system. I do not think that efficiency can be said to be 100% anywhere. What is important is the tendency to move to make things better, which we are doing by the day. That is our remit. That is what we do by the day. That is what we think about. And I think, your support has been absolutely interesting.
See, I know this issue has dominated the political scene for a while, and it's interesting that you have mentioned that increasingly things are getting better. That's not the real picture we have out there. The picture is, to the contrary, very bad.
Well, when you ask that, you ask a number of things. I was especially talking about efficiency.
Yeah,
and
okay.
When you talk about efficiency...
efficiency has to do with almost everything.
Fantastic.
And so
Fantastic.
Excuse me, but I tend to disagree. From what I have been seeing and reading, things are not that rosy.
Things are not rosy. They are like that with every health financing system, every healthcare financing system. What is important is the drive to make things better, which we are working at. I'm not saying sitting here that the NHIS is hunky-dory. It's perfect. That's not what I'm saying. It would be a lie if I said that.
For instance, he mentioned the issue of corruption. And now that we are talking about that, I think we must as well bring it up. We have people inflating invoices.
Yes. They do happen.
Yes. And some of your own officials are compromised.
I cannot say which official is compromised, but what I'm saying is that in a health finances system of the nature that we have, there is something called moral hazards. Moral hazards, if they did not exist, would not have a name. Moral hazards exist because people intrinsically will take advantage of a system. And what is important is to block those loopholes that make that possible. Now, if you talk about the US, for example, it will boggle your mind to know that even in the country that people, refer to as the doyen of healthcare, in the US, between 2005 and 2010, $4 billion was taken from the healthcare system that is financed by government in America. It happens in other ways. Some other ways in which it happens is misuse of the system. So when we talk about moral hazards, we are working to solve all moral hazards. We will not get there in one day, but we will get there.
Okay.
To a system.
Quite interestingly, Mr. Otoo admits that there are administrative inefficiencies, which is quite, for me, encouraging, because if you don't recognize that there are inefficiencies, then of course there's no way you make progress. He also assures us that they are meeting the inefficiencies head on, which is also quite assuring. But again, what we need to know is the baseline, what the situation they met is, and what they are hoping to achieve. So what is the benchmark against which we are going to measure their performance and progress? And so I think some information from the health insurance administrators in terms of what the situation was and where they want to go in terms of reducing the levels of administrative inefficiencies will be very useful within the context of the discussion we're having.
Please,
quickly,
I need to bring some clarification here on the issue of tax-based financing. In my analysis, I did mention that tax-based financing is the backbone. If you take the bad component, it will collapse. Now, when the scheme was initiated, annual premiums was expected to raise a huge amount of money. Over this 7-year period or 9, it was expected. It was expected to raise money. Now, it's struggling. And that's why we are saying that, look.
Let's hear you clearly on that point. You are saying that the NHIS
was expected to raise a lot of money from the annual premiums, because it was expected that a lot of the majority population will subscribe to it. They will pay they will get onto the scheme, and then they will raise quite some substantial amount from it. Consistently, since they review the methodology, and then they are now calculating active figures, we realize that the number of people on the scheme is relatively low, and therefore the amount of money that is coming from the annual premium is low. Because if we take the formal sector workers out, okay, you realize that we have huge proportions of the population in the informal sector who were expecting to raise a lot of money from the informal sector. But as it is now, we don't have many people on it coming from. And so that's why I'm saying that the annual premiums as a method of raising money from the informal sector has failed. The only way we can probably raise more money from the informal sector to finance the scheme, in addition to the VAT and the Social Security contribution, is to look at tax-based financing. We could have indirect taxes targeting the informal sector. Because this is supposed to be, the annual premium was supposed to be compulsory by law.
And these indirect services, and I'm also interested...
I'm sorry, but there are things that are not factually right that I need to correct.
I'll give you the chance to do that, but let him finish with his contribution. Now, you are telling us that, from your proposal, that people who do not contribute, the informal sector, there should be a way of getting them to contribute.
Absolutely.
Now these suggestions that you make, wouldn't that affect, in a way, people who are already paying, people in the informal sector who are already paying towards the NHIS?
I'm saying that the informal sector, because those in the formal sector are already paying, like you and I, we are already paying. Yes. Our Senate deduction, contributions are deducted, right, whether you register or not. That is good. That is the pooling. And the whole essence of the insurance scheme is pooling of resources so that everybody contributes in a way. So for those in the formal sector, what you like is contributed. How do we get those in the informal sector to also contribute? And that's the issue. And so the annual premium was included so that those in the informal sector will contribute to the scheme by paying their annual insurance premium. As of now, the proportion of those in the informal sector who are paying it is little. How many years down the lane?
You don't
it's
agree?
4.3. I'm sorry. 4.3 on the total
I'm sorry. You see, we should say things based on facts.
And that is a
the
fact.
NHIS has about 36% of its membership from the informal sector. That is clear, number one. The rest of the population of the NHIS are from the other categories, including children, pregnant women, and so on and so forth. So to say that the informal sector does not feature is not that absolutely correct.
The point is how much is coming from how much money is the National Health Insurance Scheme raising from the informal sector?
I'm in charge here. Please just listen to me when I tell you to hold on. I'll give you the chance. Let's allow one person to speak at a time.
The second thing is that if you say that premiums were supposed to account for a bulk of the money of the NHIS, it would have been clearly contained in the policy framework document that underlay the start of the NHIS. That document clearly stated that the predominant source of financing for the NHIS will be the NHIL, which is tax funding. So we should get this right and not, muddy the waters in fact, as far as these matters are concerned. The premiums that are collected are supposed to be, as you rightly said, adding to the pool that we have in order that those who are able to pay can support those who are unable to pay. So for that reason, if you support, getting more premiums, I agree with you. But then it should be those who are able to afford it.
Absolutely.
So let's get this clear. So you were talking about the fact that we have 34% of the population captured under the NHIS. Now, out of this 34%, we have all of them paying the premiums.
That is not correct.
That is not correct. No. Educate us on it.
34%.
How can I be a contributor without paying premium?
34% of the population of this country are active card holders, which means they can show up at a health facility and access health care. But of that number, right, 36% pay premiums. They belong to the category that pays premium. The category that pays premium is the informal sector. All other categories are exempt. So the exempt, if I'll give you the rundown, there are 6 categories. Children under 18, pregnant women, persons above 70 years of age, SNIT contributors, SNIT pensioners, and the indigent. They all are entitled to premium-free health insurance. For people above 70 and pregnant women, they do not even pay for the cost of their ID card. So all that is borne by the states. The people who pay are those who, are in the informal sector, are those who pay the premiums. And for the other categories, they pay only the cost of the card.
Okay. And I do sincerely believe that we'll need a part 2 of the discussion because we are almost running out of time. We have barely 5 minutes more to go. And within those 5 minutes, I'd like us all to react to any other issues because I saw that Mr. Hor was not in agreement to some of the statements that you made and so on and so forth. You can react to that and then give us your general overview of the solutions that we could have to all the challenges we have within the sector. Let me begin this with you, Dr. Manteaw.
Well, since we are talking about finance, I would want to focus a bit more attention. Earlier on, Mr. Otoo had indicated that ours is actually already a tax-based kind of financing arrangement, but I disagree, and I think the UK one is a tax-based financing one. Ghana's is not. Ghana's arrangement has been described as a hybrid, okay, where we rely heavily on premium and levies, but if we could move more into the tax-based finance, which is a point Sidua keeps making, that is where we reduce premiums. I'm saying that if we understand that we are dealing with a social protection issue, and therefore we should not be increasing premiums, because then once you keep increasing premiums, you're going to put many people out of assets. And so I think what we need to do is to look more at the tax area. I'm looking at innovative ways of raising tax revenue, and I think that we do not overburden those who are already paying taxes, but then there's a way in which we can put some taxes on goods that are consumed by the rich in society, so that at least you have a choice whether to consume those products. They are not necessities, they are not basic needs. And so we can look at that. We could also look at maybe like property rates, as he indicated, so that taxing people living in affluent places to cross-financing those access to healthcare for the poor. But again, we also need a redefinition. I understand that this is going to put extra burden on an already overburdened scheme. But then we need to redefine who the poor are, because I believe that there are many people who cannot afford, but are currently outside the scheme because there's no arrangement because of the narrow definition of who the poor is. And so these are issues that we need to look at if we are to expand access for majority of our people who need health care in this country.
Okay, Mr. Hor.
Yeah, thank you very much. In mentioning the categories of people who are exempt, Mr. Otoo mentioned senior contribution. I disagree with him. I pay my senior contribution to the national. It's deducted. Yeah. That's my payment.
And from the introduction, we even said 2.5%.
Yes, you can't tell me that I'm exempt. I pay for it every month. Put that aside. Yeah. It's not, but I pay. You say exempt. You say exempt.
Right.
You know, exempt. I pay, but the name is not premium. But I pay. Yeah, and also giving the example of best country. Granted, the U.S. is not the best country to cite. Thailand is one country that it has achieved universal health coverage and predominantly tax-based financing.
So we've been through all this. So
yes.
What's the solution?
Basically, we're saying that, like Steve said, there are a lot of people who cannot honestly afford healthcare in this country, vulnerable people. We should find a way of probably even doing away with the annual health premium and move towards tax-based financing. Look at the alternative we provided. There are so many sectors of the economy that are not taxed. We need to tax those aspects. People are evading tax. We need to tax them, bring the money, and we will have enough money to sustain this scheme.
Okay, so let me come back to you, Mr. Otoo. You heard him disagreeing with some of the points that you raised. And again, we know about the corruption. You, indeed, even though you were not so open about it, but you did agree that there's some form of corruption going on. And these are all factors that do affect the operations and indeed the financing of the NHIS. What are the solutions?
Well, you know, first of all, you can contain things like corruption with systems. And our approach will be systems building. You build systems in ways that allow for transparency and accountability. Once we've done that, we'll be able to nip, you know, corruption and, you know, let's not forget that, you know, the moral hazards facing the NHIS is only corruption. You also have, you know, abuse and misuse, where you have somebody showing up at 4 or 5 facilities in a day and collecting medicines everywhere. So what we are doing is to address all the moral hazards. One of the ways of doing that properly is to engage, as Mr. Manteaw said, the consumer, which I think is, you know, to an extent, is something that we've not done so well, which we have to improve on. But having said that, moral hazards can never disappear. We'll bring them to a minimum. And we are working hard towards that. One of the tools we use is IT. The other is actually, you know, punishing those that we find who are culpable. To add finally to what he said, well, the social security thing, technically it's not an exemption, but it's not a premium either. It's a solidarity transfer.
just a minute for us to just go around this one, and I'm just wondering, looking into the future, maybe 10 years from now, is it possible that we could have a totally free health service delivery where after paying the premium, as we had the one-time premium and so on and so forth, that after paying that, then that is it. We have free healthcare delivery for the rest of our lives. Is that possible?
Health care financing goes through motions and is tweaked all around. I mean, the German system was established way back in the 1800s. In 2006, Germany conducted a comprehensive review because that system, as and when you go ahead, has to change. As I told you, the context in which healthcare financing takes place, you know, is underpinned by a number of factors. Demographics. For example, when you take most of Europe, people are growing to a very old age. So the financing mechanisms and the needs will change, okay? When you take Ghana, we are now at what we call, you know, a double, we are being hit, you know, by communicable diseases and non-communicable diseases. Our context is completely different from that of other countries. Yes, Ghana is committed, and it will interest you to know that Ghana is probably the only country in sub-Saharan Africa doing what we are doing. It is an experiment that as a country we all undertook to do. We are doing it to the best of our ability currently. I think everybody is supportive. we need to continue that support and collaboration to bring this to
Dr. Manteaw, your last comments on.
Well, I'll offer in terms of further suggestion in terms of how we raise finance for the health sector. We could be looking at the mining companies. We could be looking at the oil companies. We all agree that where there are mineral extraction, there are likely to be a high incidence of certain type of diseases, and these diseases also put a burden on the national health budget. And so, for instance, I'm not saying that mining companies should be taxed, but I'm saying that we set up various funds. For instance, we have the Minerals Development Fund, and part of it can go to support the NHIS. We also have the annual budget funding amounts, 70% of the petroleum revenue that goes into the budget. Of course, they are to be spent on 4 priority areas in every medium term. We could prioritize the health sector as one of the areas we want to put money into.
And is it about time that we begin to look at those companies who are tax exempt? You know, there are some waivers that we give to some companies. Is it about time to review all these things?
Well, that is already happening. I mean, if you look at the mining sector, we've actually carried out wide range of tax policy reforms.
All right, I need to move on.
We are renegotiating stability agreements that actually has an inhibiting effect on our ability to collect taxes in the mining sector.
Mr. Hor, within 15 seconds, can you round up our discussion for us, please?
Yes. Ghana can achieve universal access to healthcare free at the point of use. Free means, at the point of use, means that we would have paid for the money before we fall sick. And we can achieve this if we make sure that we fix the inefficiencies within the health system. It's not only about National Health Insurance Scheme. We talk about Ghana Health Service, the Ministry of Health. We have leakages in the health system. We need to seal those. The private healthcare providers that are under the National Health Insurance Scheme, we have to put a strong gatekeeper system there to make sure that we monitor them very well to ensure that people get value for money. Then they can believe in the system. And then we also have to make sure that we strengthen our revenue collection. Like Steve mentioned, we need to expand the base. For example, the free zones waiver that we give to companies, has it really yielded the needed benefit? We need to re-examine it and probably take it off, and then we'll bring more money into the health.
Thank you very much. This has been Talking Points. My name is Abdul Hayi Mumin, and with us to do the discussion tonight are Mr. Nathaniel Otoo, who is the Acting Deputy Chief in charge of operations at the National Health Insurance Scheme. Next to him, Dr. Steve Manteaw. He is the campaigns coordinator at ISODEC. And then Mr. Sidua Hor. He is the national coordinator, Universal Health Campaigns, and he's also a health policy analyst. I'd like to say good evening to Nana Osisi Adan in Tema, and of course Mr. Jacob Osei-Yeboah, who was the independent presidential candidate during the 2012 election. They are loyal viewers of Talking Points. Have a very good evening, and do join us again next week when we bring you another edition of Talking Points.